delay, we'll start the session. So I'll be just sharing my PPT. Just let me know once you see it.
Sure.
Is it visible?
Actually, no, ma'am. Yes, it is visible now.
Visible? Yeah. Okay.
Please
Give
go
me a
further.
minute. Okay.
Yes, ma'am.
Okay. So we'll start with GI symptoms. So what we'll cover today, am I audible?
Yes, ma'am. You are audible
Bit of
clearly.
disturbance on this side, but I'll try to be louder. Okay, so we'll be covering various GI symptoms. So what we are covering would be basically nausea, vomiting, hiccups, constipation, and a bit about malignant bowel obstruction because it's one of the common presentations that we see, especially in oncology. So coming to nausea, vomiting, we've all had at least one episode of vomiting in our life. So how does it feel? Is it very pleasant? Can anyone just tell me write it on the chat box. That's also fine. I'll be reading it. Okay. So can anyone share their experience of when they had either nausea or vomiting? So how was it? Was it pleasant? Did you enjoy that feeling? No. It's one of the most horrible feelings that you have, right? Like the whole burning in your throat, and it's basically awful. So what we need, that's why it becomes one of the very important what do you say, symptom to manage well, because it leads to a lot of distress and discomfort, as you've correctly said. So in management, what we need to remember is that there can be two ways to manage the whole thing. One is either to identify what is causing the said nausea, vomiting, and then treat the cause, or either is that you can identify which pathway is involved and then block that pathway. In a way, both are overlapping with each other because the cause would be via a certain pathway. So the management would tend to be similar, but sometimes it may differ as well. Okay, so can anyone just quickly tell me what are the causes of nausea, vomiting that you get off your head? Like what would be the commonest causes that you would think for nausea, vomiting?
Ma'am, indigestion.
Indigestion, excellent. Okay, anything else? Indigestion, gastritis, one of very common things that we have. Anything?
Any GI obstruction or any kind of GI disorder.
Yes, excellent. Smell.
And also
Yes.
chemotherapy drugs also have side effects of nausea and vomiting.
Yeah, so drugs. Let's just stick to drugs. It can be any drug. So as UG students, we would often say that, side effects mean nausea, vomiting would be the first thing that we say for any drug. So drugs, especially chemotherapy, therapeutic agents, overeating, indigestion, gastritis, GI problems, hemorrhage. Can you be more specific about hemorrhage? Do you mean like a GI bleed or something of that sort? Ulcers may be leading to GI bleed, may cause nausea. Yes. Anything else? Yes. Anything else? Any organic causes? Let's start from the head downwards. Like start from the brain going downwards. So what are the causes that you can think of in the head?
Migraine.
Migraine. Yes. Anything else?
Any blood clot that has been there in brain.
Okay. Do you mean to say raised intracranial tension or pressure?
Yes, ma'am. Raised IC.
Okay, so raised ICT. So it can be because of, let's say, either a mass lesion or meningitis. Okay. Coming down, any other causes in the head region? Allergy, food allergy, okay. Yeah, okay. Head downwards, maybe a motion sickness. Motion sickness would also cause nausea and vomiting, right? And then coming down, you have your GI tract, your so we said all those things. So anything in the abdomen apart from gastritis and hemorrhage, as we've said, anything else?
Increased bile pigments sometimes also causes nausea, vomiting.
Okay, so maybe let's make it a bit broad and let's just say hepatic system, something to do with the hepatic system and maybe the renal as well. Okay, GERD, yes. Anything else? Okay, so let's just come to the causes. So above the neck would be any mass or metastasis, as we said, meningeal irritation, migraine and headaches, and movement. Movement would be your basically motion sickness that I mentioned. Below the neck would be again any mass lesion causing obstruction or decreasing the motility of the GI tract. There can be mucosal irritation, which can be because of the hemorrhage or gastritis or GERD, as we've said. Any obvious mechanical obstruction, myocardial infarction, and maternity. Then we also have, what do you call it? Just systemic causes. So systemic causes would be anxiety, medications, any infections, or any metabolites which may lead to nausea. So medications, as we said, chemotherapeutic agents or any other medications which are prone to have a lot of nausea, vomiting. For example, even opioids have a high tendency for nausea. So those anxiety, as we all know, so when we are in a high stress situation where we are overtly anxious, sometimes we do feel a bit nauseous and sometimes people do get vomiting because of that said anxiety. Infections, as we all know, enteric infections, any enteric infections may lead to nausea, vomiting, and metabolites. So sometimes in certain metabolic dysfunctions, there can be nausea or even vomiting. So another mnemonic to remember is vomiting itself. So vertigo or vestibular system that is affected, any obstruction or severe constipation, any motility dysfunction, inflammation of the gut, toxins, intracranial pressure, nerves and anxiety, any oral lesion which is leading to nausea. Okay, so what are the pathways? What are the main receptors, or what are the main centers that are involved for nausea, vomiting? Pyrolics, yeah, okay. So what are the pathways? What are the main pathways that are involved in nausea, vomiting? Anyone? So we have the chemoreceptor trigger zone, which is in the brain medulla, and we have the vomiting center, which is down below. So basically your CTZ is above the blood brain barrier, nausea vomiting center is outside of blood brain barrier, right? So basically what you're looking at is the chemoreceptor trigger zone and the vomiting center, which are the main ones. Then you also have the cortical sensations, vestibular because of the vestibular canal basic. So that is one center, and peripheral would be your GI tract. GI tract mostly in the upper GI tract. So what are the neuroreceptors? Those are neurokinin, serotonin, dopaminergic, acetylcholine, histamine, and GABA. Those would be the main receptors that are involved in the whole process of nausea, vomiting. So center-wise, if we say, chemoreceptor trigger zone has mainly dopamine and histaminergic. Vomiting center has 5-HT3, NK plus histaminergic as well. Cortex would have your GABA. Vestibular has your histaminic and acetylcholine. GI tract specifically has 5-HT3. So basically, if you know which receptors are present where, then according to the pathophysiology or according to what is causing the nausea vomiting, you can target those specific receptors according to specific like which receptor you want to block. So antidopaminergic or antihistaminic, antagonist, 5-HT3 antagonist. So if you remember where you want the drug to act, it becomes easier for you to manage the nausea vomiting. So as we saw earlier, so the way to manage is either to identify what is causing the nausea vomiting and then treat that underlying cause, or the other way to do is identify which pathway is involved and then block that pathway. So basically for any symptom management, this is applicable. So basically the dose should be round the clock. It should not be that it is just once a day or twice a day and the effectiveness of the medication goes off in like 6 hours. So that should not be the way. The medication should be given throughout the day to last for the whole 24 hours. So the dose should be titrated accordingly. So it should be according to the T half of the drug that is being used, and the dosing schedule should be managed accordingly. Then titrate to effect. Titrate to effect is that you can start with the lowest dose for the particular age group or for weight, and then increase the dose if you find that the symptom is not completely relieved with the said dose. Then weigh in the benefits versus the side effect profile for the drug. So if the side effects of the said drug is outweighing the benefit from the drug, then it's better to switch on to some other class of drug to manage the nausea vomiting. And it's also important to remember that if the first line of management or first drug that you're using is not as effective and you think that it'll be better to add another drug, it's better to switch to a drug which has a different pathway in which it acts. So if you're giving an antihistaminic, then maybe it's good to add a 5-HT3 antagonist along with it instead of adding another antihistaminic to it. So it should be of different mechanism. So certain non-pharmacological measures that can be used to manage or reduce nausea vomiting would be all of these. Cognitive behavioral therapy basically would be more beneficial when there is some psychological aspect to say nausea vomiting. For example, as we were saying, a lot of chemotherapeutic agents have a lot of nausea vomiting. So what the patients develop is the fear of getting that nausea vomiting or fear of vomiting because of the said chemotherapy. So, and it might still be true that because of the drug, they would end up getting they would end up puking a lot post those days. But let's say if the regime has changed, if they've changed from, let's say, a high emetogenic drug to a lesser emetogenic drug, or they've changed the cycle from first line to second line, and the nausea should not be more, but they still feel a lot of nausea, especially before the said schedule of that drug. So they generally start feeling a lot of nausea vomiting 24 to 48 hours before they receive the medications. So this is more of psychological aspect of nausea vomiting because they've experienced that severe nausea and severe episodes of vomiting because of the drug. So they have this psychological tendency which says कि okay अभी मिलने वाला है तो मुझे nausea होना ही है. So they started beforehand is only. So certain behavioral patterns can be modified to manage them. Again, this takes in a lot of time. It does not happen with just 1 or 2 sessions. It would need repeated and multiple sessions to manage the said nausea vomiting. So it's a slow process, but it can be given as an additive measure along with the drugs. Then acupuncture, relaxation, hypnosis work wonder. And if it's available in the locality where you're practicing, it would be beneficial to inculcate that in the routine practice as well. Can you just hold on a minute? I'll just shut the door. It's a bit noisy. Yeah, sorry about that. So in case acupuncture and relaxation techniques or any psychologists are available who would help with the relaxation techniques and hypnosis are available in your place, it's good to kind of integrate them in the department just to have a holistic management to nausea vomiting. Then the routine घर के नुस्खे that you can give is कि avoid a very strong smell of food in the house. For example, जब तड़का देते हैं, so it's kind of pungent. So that pungent smell induces or increases nausea. Might not lead to vomiting, sometimes might lead to vomiting, but kind of avoiding these strong smells in the house or even incense lighting, sometimes those might also trigger a lot of nausea and vomiting in the patient. So avoiding very strong smells in the vicinity of the patient goes a long way to manage them. Eating small meals, frequent meals, so that they have adequate nutrition, but also you're not making them overfull, which would trigger vomiting in some cases. Then also giving cold food. So basically, cold food like toast maybe or biscuits, they are less emetogenic, like because it might be because they have a no smell to a very soft smell, I would say. So that might go hand in hand with why they are better tolerated, but certain foods like that are better tolerated than hot warm food. Then ginger water or ajwain water sometimes help with just managing nausea a bit better. It might not completely relieve the symptoms, but just have that feeling of decreasing in the intensity of nausea. So these should be explained, especially the last 3 months can be explained to the patients and they can do it at home. The rest of them, if they are available at your places, excellent. If not, then maybe having a person get trained in those, at least acupuncture and relaxation techniques go a long way. Then medications, as we all saw, so it's basically acting on the receptors that we saw. So dopamine antagonists, 5-HT3 antagonists, NK antagonists, prokinetics, antihistaminics, anticholinergic, steroids, and benzodiazepines help as well. So these, again, just to recap, these are all the centers that we want to target and the drugs. So let's come to a very small case. We'll just please type in or please feel free to unmute and answer. So basically, it's a 70-year-old female with an advanced ovarian cancer. There is increasing in abdominal pain since last few weeks, and there has been increase in the opioid dosage or change in the opioids in the past week itself. Now there is constant nausea that the lady is suffering through. So what would be the potential reason for her nausea? What can be the potential reasons for nausea? Let's say there are multiple reasons that we can think of. We'll have to come down to one. So what can be the reason?
It can be due to opioids.
Opioids, excellent. Okay, so opioids. Anything else?
She may also have some abdominal disorder because she's having abdominal pain also.
Okay, so the pain itself might kind of induce or increase the nausea. So the pain itself or any abdominal dysfunction, as you said. What abdominal dysfunction that we can think of in a case of advanced ovarian cancer? So it can be a mass effect, like if it's an advanced ovarian
It
cancer.
can be metastasis. Metastasis can be there.
Yeah, so it can be some mass effect leading to maybe an obstruction, or there can be ascites, which is leading to increased abdominal pressure, which would lead to abdominal pain and maybe again hamper with the motility of the GI tract. So these are just that come, on the top of my head, that can be the potential reasons for the nausea in this case. So it's basically you're stimulating the chemoreceptor trigger zone, right? So, and the receptor that we are looking at is haloperidol or 5-HT3. So either of them will work. So dopamine antagonist would be haloperidol or olanzapine. 5-HT3 would be ondansetron. So either of them work. Why one is preferred over the other, we'll discuss again later, but either of them would work here. Okay. Now coming to another case, it's a 46-year-old lady with diabetes and metastatic colon cancer with liver involvement and malignant ascites. There has been chronic nausea in this patient with intermittent amount of vomiting. There is a lot of reflux and a lot of bloating. Eating makes the symptoms worse. So what are you thinking about in this case? What can be the causes? Anyone?
Since it is reflux and bloating, it might be indigestion because she is having metastatic colon cancer, so digestion process is not properly being taken.
So decreased motility maybe because of whatever reason. So indigestion and decreased motility leading to reflux and bloating. Another reason, another possible cause can be GERD. Okay. And the liver involvement with malignant ascites. So that means that it's sort of like going into hepatic failure, you would think of, because ascites is there. So it's maybe not like outright hepatic failure, but going towards hepatic failure maybe. So we don't have enough information, but if the liver parameters are raised, then that can also be one of the reasons for nausea. So let's just break it down. So basically here, as you correctly said, it's indigestion or decreased motility that you're looking at. So peripheral pathways affected and your central pathways affected as well. So 5-HT3 or dopamine. So basically here you would want to increase the motility. So prokinetic have to be given, that is metoclopramide, or dopaminergic antagonist would be haloperidol. Right? Any confusion till now? Is that clear? Okay. Moving on. Another case, a 38-year-old male with metastatic melanoma, acute onset of vomiting, which is worse in the morning, and reports headache without neck stiffness. So what are you thinking about? Any meningeal involvement maybe? Raised ICT?
If there would be meningeal involvement or meningitis, it is characterized by stiff neck, but he's not having any stiff neck.
Okay, so maybe raised ICT?
Raised ICT can be the cause.
Okay. So because it acute onset, worse in the morning, headache is there. So maybe you're thinking about some raised ICT or some basically some intracranial involvement. So basically here it's the cortex. So cortex we have either histaminergic 5-HT3 acetylcholine. Here I've written dexamethasone because that helps in reducing the raised ICT and works that way. But you can give, so 5-HT3 antagonists like ondansetron work wonders in nausea vomiting because of raised ICT. So that would be the first choice along with dexamethasone to reduce the pressure, intracranial pressure. Okay. Is this clear? Like, was nausea, vomiting clear? Or was there any confusing part that we need to go back and maybe have a look again? If it's clear, then we'll move forward. Okay. So coming to hiccups, basically one of the very distressing in the sense this is very irritating to day activities basically. So the hiccup center, as we call it, is in the upper spinal cord. So C3 to C5. Basically that is what triggers. So your vagal stimulation, basically, that is what would trigger the just a minute. Yeah. So activate, basically what happens is that there is stimulation of the vagal or the phrenic afferents because of either the viscera surrounding the diaphragm, either thoracic or abdominal, which activates the hiccup center in the midbrain brainstem region, and which stimulates the efferents, which then go down via the phrenic and the intercostal nerves and causes repetitive myoclonic contraction of the diaphragm and the other respiratory muscles, which then leads to the activation of the recurrent laryngeal nerve, which basically closes the glottis. And because you're expiring at the same time, and because of the closed glottis, you basically have that hic sound. So that is how the hiccup is actually produced. So it is pretty not a very common symptom that you see. Generally more in GI tract or GI diseases. Sometimes that might, like in 20% of the cases, that might be the reason why the patient comes to you. Most of the time it's because of the reflux diseases that nowadays almost everyone has. And in advanced cancer, it is seen in around 4 to 5% of the patients. So basically can be divided into acute, which is lasting for less than 48 hours, persistence, which is more than 48 hours, and intractable, which is for more than a month. So this can be divided into such. So acute causes would be, acute causes would be drinking a lot of carbonated water or beverages, alcohol, eating too much too fast, any emotional reactions like laughing a lot may sometimes, just start off the hiccups in a person. Sudden temperature changes might sometimes lead to hiccups. Swallowing air with chewing gum or sucking on a candy. So some, sudden irritation of basically the diaphragm would lead to acute reasons for hiccups. Then coming to persistent or intractable causes. So any nervous system damage or nerve damage or irritation. Sometimes it can be just like simple as hair touching your eardrum or something, tumor or cyst or goiter. GERD, sore throat or laryngitis, alcoholism, anesthesia, barbiturates, diabetes, electrolyte imbalance, kidney diseases, steroids or any other drugs, and tranquilizers. So a few of the chemotherapeutic agents also have, I wouldn't say a tendency to develop hiccups, but a tendency for gastritis, which then leads to the patients having hiccups. So that might be like secondary to gastritis, but it's still fairly common. So central nervous system disorders, basically your normal control over the hiccup reflex is gone. So that's why it triggers a lot of hiccups. So in encephalitis or meningitis, multiple sclerosis, stroke, any traumatic injuries or tumors. So coming to the management, it's fairly a very small topic. So in general practice, like according to the guidelines, its first line is baclofen, GABA or pregabalin. Then second line would be your prokinetics that are used. But in general, what I have noticed in daily practice and when we were learning as well. So the first thing that we give is, because we always presume that it is because of a lot of gastritis or GERD. So we would tend to start with a high dose of PPIs, maybe pantoprazole or omeprazole, along with your antacids. So liquid antacids were given, along with a prokinetic. So metoclopramide or domperidone, whichever is available or whichever you prefer. And then if that is not helping, then we would go to baclofen. Usually we would start off with the dose of 5 mg thrice a day and then escalate it if necessary. Then the next drug that was added was haloperidol, 0.5 to 1 mg HS. That can also be titrated up if required. And then if nothing is working, then we would go on to gabapentinoids. So third line here is chlorpromazine. Others are your carbamazepine, valproate, phenytoin, nifedipine, and amitriptyline also be used. Physical or non-pharmacological techniques that can be done are your nasopharyngeal stimulation. So basically anything that would your Valsalva or cold compress, carotid massage, those basically help. Your intranasal vinegar or any stimulant irritant inhalation also help. Might not be that beneficial, but you can try it nevertheless. So basically you want the vagus to get stimulated to reduce or get the control back from the reflex center, hiccup center, sorry. Then breathing maneuvers, as I said, Valsalva or rebreathing, rebreathing masks, so mask in the sense, rebreathing bags, or CPAP respiration, or breath holding, inspiration and expiration both. So naak band karke ye rakhte hai, so that can also help. Another thing that you can try is hypnosis acupuncture. And if it's not getting control and it's intractable, then you can even think of getting a nerve block, especially in the C3 to C5 region, or the phrenic or the vagal nerve. Vagal nerve stimulator can also be placed, or for neuromodulation basically. But these are very invasive procedures, so these should be this should be the last resort for managing hiccups. Are we clear till now? I mean, is hiccups clear? It's a very small topic in the whole GI tract because it's fairly rare. But it's just thought that maybe we should cover that as well. Okay, so coming on to constipation. So basically, what is constipation? It is persistent, difficult, infrequent, or seemingly incomplete defecation. Okay, now why I've mentioned seemingly incomplete? It's basically you get that feeling of incomplete evacuation. It might not be so, but you get that feeling of incomplete evacuation. And also this is very subjective in the sense that you need to know what is the previous normal regime of bowel evacuation for the given person as well. So if the normal for that person is going to pass the stools every second day or third day, then that is normal for him. So he's not constipated. For others, it might be that they go daily, and now because of whatever reasons they're going every alternate day or every 2 days, then that is constipation for them. But for some people, it might be a normal regime as well. So you need to ask that history well before you prescribe any medications for constipation. Okay, so what are the colonic functions basically? What does a colon do? What is its function? Normal function. Anyone? Sorry?
Peristaltic movement.
Okay, so basically pushing on the digested material forward and fluid reabsorption. Basically, a majority of reabsorption of water that goes on is in the colonic part of your GI tract. So those are the two main functions of colon. Now this is the basically the nervous system, enteric nervous system of the colon. I'm not going into the details. So basically, if we come to the fluid balance, which is the major part which we will be focusing on for constipation. So basically, let's say you take around 2 liters of fluids orally, okay, and a lot of secretions that go in. So around 7 liters of secretions are produced endogenously. So for example, you can say saliva through your stomach, you bile, pancreas, and intestine. So that leads to 7 liters. So approximately there is 9 liters of fluid in your GI tract. Reabsorption में small intestine absorbs around 7 liters of fluid. Colon and rectum absorbs around 1.9, that is approximately 2 liters. So that the amount of fluid that is excreted out via the GI tract is only 0.1 liter. So that is 100 ml. So that is comparatively very less. So so this balance, if disturbed, would lead to formation of hard stools or impaction of stools because it's not able to pass out very easily. So this balance should be maintained adequately, right? So what happens is basically you have various reasons for constipation. Like, so food bulk is low. So basically there is no fiber in your diet. It's all carbohydrates and all. So it becomes very less bulky basically. So normally when you pass stools, what happens is that there is distension of the large intestine, which leads to the peristaltic movement, which then pushes your stools outside. So that is the simplest way of explaining the normal peristaltic movement. Now, if the bulk is low, there won't be any, or there would be improper distension of the gut, basically, which leads to inadequate peristaltic movements, which lead to incomplete evacuation or no evacuation, if that is the cause. And it can be psychogenic reflex disorder, anism, for example. So basically, instead of dilatation, there is contraction of the pelvic floor, which leads to inability for it to pass out. So basically, it leads to constipation. Any surgery or trauma or peritonitis, as we all know, it can, because as a protective and reflex, it basically causes paralytic ileus. So basically, your gut just shuts down. So it gradually recovers on its own, or with, sometimes with the potassium supplements and everything. So it generally recovers on its own. There can be a mechanical obstruction. So it can be an extrinsic obstruction or intrinsic obstruction, which can lead to inability to pass the stools from the gut outside, or any neurogenic or myogenic disorder, or drugs sometimes, which lead to decreased motility of the gut, which leads to constipation. Okay, so these are basically what we would call the pathophysiology, like just to enumerate what the various reasons for developing constipation would be. Now, as I said, endocrine causes, diabetes, thyroid disorder, or hypercalcemia, basically what they do is they decrease the motility of the gut. So that's how it leads to more or increased risk of developing constipation in these patients. Any neurological disorders like spinal cord injury or MS, Parkinson's, they basically have the sphincter control is lost. So that might either lead to passing the stools without their knowledge, or not passing the stool despite various medications. So you have to give enema every other day just so that they pass stools from by that. Any anorectal disorders like fissures or strictures or IBD. Anal fissures are very painful. So the patient himself or herself would not want to pass stools because it induces a lot of pain, which leads to increased constipation, hardening of stools, and basically worsening the fissures if they pass it whenever they do. So this can lead to a vicious cycle. Any psychogenic disorders like depression or any eating disorders may also be a potential cause for constipation. Any iatrogenic causes like drugs or surgery, and lifestyle or dietary patterns with a low fiber content or low residue diet. So non-pharmacological measures would be a fiber-rich diet to increase the bulk, increasing the physical activity so that the gut motility is also maintained well, increasing the fluid intake so that the stools that are formed are soft and are easy to pass, and a regularized or a ritualized bowel habit. So a certain time fixed for passing the stools is a good way to kind of make it into like a scheduled thing rather than whenever you have to go, so that the gut also gets into the habit ki abhi itna baja hai to I have to go, that sort of thing. Pharmacological measures would be basically to increase the bulk so that there is distension and peristaltic movements. Surfactant to make it soft or to make it easily able to pass through the gut. Osmotic agents to increase the water content in the stools. Stimulant laxatives to increase the peristaltic movements. And pamoras, they are mainly used for opioid-induced constipation. Basically, they are peripheral antagonists of mu-opioid receptors. So they would be specifically used for opioid-induced constipations. Okay, so as I said, bulk producing is basically they increase the bulk of the stool so that there is more, it improves the peristaltic movement basically. So they will work both in small and large bowel. Stool softeners would soften the stools basically, mainly for colon. They work in the colon. So what it does is it makes it easier to pass the stools. Lubricants or emollients, basically, again, the hard stools are kind of softened or surfactant sort of. So basically, they kind of form a coating around the fecal matter and again help in passing the stools easily. Hydrating agent increase the water content of the stool, making it soft and easier to pass. Stimulant would increase the peristaltic movements. So basically, others would contain prostaglandin analogs or prokinetic, again to increase the peristaltic movements or the motility of the gut and the change in the absorption and reabsorption of water and electrolytes in the intestine. So small bowel में जो act करते हैं anti-constipation agents would be your castor oil, polyethylene glycol, lubiprostone or linaclotide. In the colon, we have bisacodyl, senna, lactulose, and hyperosmolar salts. So lubricants, as I said, basically they help to ease the passage of stools in from the gut. So options would be your oil enemas, glycerin suppositories, or docusates. Increasing the motility are basically your prokinetic agents, which are bisacodyl, senna, or you can even consider domperidone or metoclopramide as prokinetic agents. So what are the various medications that would cause constipation? Since we said that, drugs are one of the reasons why there can be constipation. So what are the drugs that you know of are constipating in nature? Anyone?
Codeine.
Codeine. So opioids. Okay, excellent. Anything else?
Antituberculous.
Okay. Anything else? Or anti-Parkinson's. Okay. Let's just go. So basically analgesics, as you said, opioids are constipating, anticholinergic, are anti-inflammatory, yes. So analgesics, anticholinergic, your calcium channel blockers, diuretics, generally the non-potassium sparing type. Iron is highly constipating. Then you have your sulfonates, polystyrene sodium sulfonates, antacids which contain calcium or aluminum specifically are constipating, barium salts, clonidine, any ganglionic blockers or muscle blockers, because again they'll reduce the motility, and ondansetron. So 5-HT3 are constipating. Okay, so coming to a case, this is a male with a gastric cancer. He's admitted for pain crisis. So current medication is diltiazem, Docusate, GABA, ibuprofen, morphine, plus codeine, and Miralax. So basically that is for constipation. So how would you proceed with the management? So basically opioid dose was recalculated. There is no oral equivalent of morphine that was used for him after titration is around 70 mg, but he still feels constipated, and the last bowel movement was 3 days ago. So what are you thinking of in this case? What might be the reason for constipation? Maybe opioid itself might be causing constipation. So the thing to remember is that the constipating effect of opioid does not go away. So the most acute side effects that you would see of opioids or morphine is nausea, vomiting, sedation, and constipation. Nausea, vomiting, sedation goes off in 3 to 5 days, but constipation remains. So constipation is the one side effect that does not go away as you continue to give opioids. So constipation here would be mainly because of the morphine. So so basically, as I said, constipation was an issue since beginning the opioid therapy. So then they later added Senna as well as Docusate with polyethylene glycol and bisacodyl suppository as and when needed. And then they started on. So basically here, can you think of Pamora? Maybe that would be useful. The as I mentioned before, like those peripheral antagonist of mu opioids, mu receptors basically. So methyl naltrexone. So unfortunately, it is not available in our country. The peripheral antagonists. We have naloxone and everything, but we don't have peripheral antagonists. So unfortunately, it's not available in our country. Or maybe we'll have to see where all it is available. As far as I know, I've tried to find it, but I couldn't. So we'll have to work on that as well. So another case, 57-year-old female lady, again with the stage 4 ovarian cancer. Now she's having continuous colicky abdominal pain. She also has abdominal distension. She has not passed stool since the last 7 days. There is nausea and vomiting. So the vomiting is basically acute, large volume, and contains undigested food particle. And there is relief after vomiting. So is this patient constipated, or is there anything else that is wrong with her? Any comments? Is it just purely constipation or anything else that you're suspecting, given the case and the symptoms? Sorry about that. Anyone? Anyone? Okay, so maybe a malignant bowel obstruction. Now, from why I'm saying that, it is an ovarian cancer which has a propensity to spread intra-abdominally a lot. So there might be peritoneal deposits, there might be lymph node involvement, abdominal lymph node involvement, which may lead to external obstruction of the intestines. And the symptoms that are pointing towards them are the colicky abdominal pain, which is continuous, and abdominal distension, and has not passed stool since the last 7 days, with a large volume vomit test that she's having. So they point out towards malignant obstruction. Now, basically, what will happen is that there is ineffective motility because of the occlusion of the lumen. Then common cancers that are usually affected would be your abdominal or the pelvic primaries, or metastatic from any other region, especially lungs, breast, or esophagus. Now, it can be large bowel obstruction or a small bowel obstruction. It can be complete obstruction or partial obstruction. Now, if it is an operable type of malignant bowel obstruction, then the mean or median survival is around 4 to 6 months. If it is inoperable, then it comes down to 4 to 6 weeks. So that is the prognostic significance of a bowel obstruction, malignant bowel obstruction. Now, coming back to that case, as we said, what do you think? Where would be the obstruction? Would it be an upper GI obstruction or a lower GI obstruction, based on the symptoms that she is having? I would say it is an upper GI obstruction, just because there is a acute onset of vomiting with large volume of undigested food particles and the relief after emesis. So I would say it's an upper GI obstruction. Now, coming to the whole cascade or the vicious cycle of obstruction of a bowel obstruction is basically that because of the interruption in the movement of the stools via the bowel, there is increase in the luminal content, which in effect increases the epithelial surface area of the gut. Plus minus, there is bowel distension, again leading to increased surface area, which basically because of the distension, there is a lot of fluid secretions with sodium and chloride secretions into the bowel lumen as well, which again leads to increased distension of the bowel, which in itself would lead to nausea and vomiting, because there is all this fluid that is getting accumulated into the gut. Now, because of the distension, as we saw earlier, the peristaltic movements get activated. So there is a lot of bowel contractions, which lead to colic. Can I just have 1 minute? Just forgive me for this. Hello. Hello. Ma'am, wait a minute. Yeah, sorry about that. Okay, so where were we? Yeah. So what happens because of the bowel distension is that your bowel contractions are also increased, which lead to colicky pain. Now, because of the distension, because of the involvement of the gut, so there is continuous abdominal pain, which is different from colic. It's not because of the peristaltic movement. It is just because of the stretch of the gut wall that you get this continuous abdominal pain, which again So distension would again lead to a damage in the intestinal epithelium, which would make it a more hypertensive state or more inflamed state, which would again lead to a colicky pain as well as the continuous pain. Now, because of this inflammatory status of the lumen of the intestine, what happens is there is inflammatory response, which lead to the production of prostaglandins or other secretagogues or nociceptive mediators, which would cause hyperemia and the edema of the wall itself, which would again lead to increasing in the bowel secretions of fluids and electrolytes. So this is the vicious cycle that goes on. So what in the management, it's good to remember this so that we can manage it by addressing certain aspects of it, so that there is holistic approach to the management. Now, so as I said earlier, if it is reversible or operable, it has a good prognosis. If it is not operable or irreversible, the prognosis becomes poorer. If coming to the non-surgical management of obstruction, so again, it can be divided into managing a partial obstruction or a complete obstruction. So initial management remains the same. What you have to do is basically give gut the rest, put in an NG tube, which is a temporary procedure. And again, the prognosis, as I said, would depend upon how manageable it is. If it's reversible with surgery or without surgery, the prognosis is better than what it is if it is inoperable. Now, interventions that are possible here would be a stenting of the part of the lumen where there is obstruction, surgery if it is possible, and decompressive interventions, as I said, nasogastric tube or venting gastrostomy. But again, venting gastrostomy becomes difficult if there is presence of ascites or peritoneal carcinomatosis in certain cases. Now, coming to the management. So, increased luminal content hai, so we can think of pushing them out of the gut, right? So, a prokinetic, but only if there is partial obstruction. If it is complete obstruction, then giving a prokinetic would increase your contraction or basically the peristalsis, which would further increase or exacerbate your colicky pain that the patient is having. So prokinetic is helpful only if it is a partial obstruction. Anti-secretory to basically reduce the edema of the wall and reduce the content or the fluid secretions via the lumen. Then antiemetic to manage the nausea, vomiting. Steroids to reduce the inflammatory process. And analgesics to manage both the colicky pain as well as the abdominal pain. Now, if it is partial obstruction, your aim is to get the functioning of the bowel back to its previous state. So basically, you want to get the bowel to start moving. So here there is no need to add in an anti-secretory agent, but to up the dose of laxatives plus minus prokinetic, which depends upon if there is a lot of colic, then adding a prokinetic would increase your pain. So you need to kind of go individually whether it can be used in the certain patient or not. Dexamethasone to reduce the edema or the hyperemic or the inflammatory state of the intestinal lumen. Antiemetics, because we have to manage the nausea, vomiting. And using opioids sparingly or switching to an opioid which is less constipating would be the way to go. If it is a complete obstruction, the management changes where you want to give the gut a complete rest. So you want to shut down the gut completely and give it absolute rest to reduce whatever is going on inside the lumen. So dexamethasone, again here, it would be useful to reduce the inflammatory response and the edema in the lumen. Opioids you would prefer here because it will manage the pain, and you want to shut down the gut, right? So you want to stop the peristaltic movements in general. So opioids are anyway constipating and would decrease the motility anyways. So opioids are preferred here. Anti-secretory agents to reduce the secretions that are coming into the guts. So your fluids and your electrolytes, basically it will help reduce those secretions into the lumen. Antiemetics, again, you would use generously because there will be a lot of nausea, vomiting. And a venting gastrostomy or NG aspiration is valid because there is a lot of secretions that are accumulated in your stomach. So just removing that would help manage the nausea and the vomiting very well. So again, coming down to a case of a cervical cancer patient with peritoneal carcinomatosis. She's been admitted in the hospital for small bowel obstruction. The current medications that are going on are metoclopramide, Dexa, haloperidol, octreotide. Do you think this is the correct way to go about it, or is there something else that you would have given or not given in this case? Anyone? Maybe unmute and then anyone?
Yes, medication regimen is appropriate.
Appropriate. You would not have changed anything. So basically, we don't know if it is partial or complete obstruction, but since they've given metoclopramide, you would assume that it is a partial obstruction. So in partial obstruction, generally you would not give an anti-secretory because the bowel is sort of functional. So it's not like completely blocked where the secretions and the bowel contents are getting, filled up in your GI tract. So anti-secretory, that is octreotide, would not be given in a partial obstruction, which seems to be the case given there is an prokinetic that has been given. So apart from that, it is correct. So apart from octreotide, the rest of the management is absolutely correct. Okay. Continuous pain के लिए opioids, colic pain के लिए your anticholinergic like glycopyrrolate or hyoscine, and anti-secretory like octreotide. Okay. So nausea vomiting के लिए, if it's partial, then you can give metoclopramide because it will act as a prokinetic as well. Octreotide would help with nausea vomiting because it will reduce the secretion and thus the content of the lumen. So because there is not a, it helps reduce the distension of the lumen of the gut. Then that's why it will help with the nausea vomiting. Scopolamine again would reduce the reduce your what do you call it, the movements, gut movements, and then help that's why it will reduce your nausea vomiting. And haloperidol as an antiemetic agent itself. Okay, now common doses of the medications that are given. So dexamethasone, basically you give from 6 to 16 mg IV in divided doses daily. You can give it as once daily dosing as well. You can go up to 24 mg per day as well. Glycopyrrolate, generally we use hyoscine and not glycopyrrolate. So buscopan, that is what we generally use. So buscopan would be given in the dose of 20 to 40 milligrams thrice a day. Octreotide is titrated in 0.2 to 0.9 mg per day subcutaneous or IV infusion 8 hourly. So you'll have to calculate it thus. And metoclopramide, if advised, that is in partial obstruction, then 10 to 20 milligrams every 6 to 8 hourly. These are the common dosage. Yeah, so that's about it. Any questions? Any doubts that you might have?
Thank you, ma'am, for that presentation. Participants, if having any questions or doubts, kindly unmute from your end, else you can use the chat box. Any questions or doubts? I guess your presentation was so clear now. Now it's coming up.
If you have any doubts, please feel free to reach out via anyone. And I'll share the presentation with you so you can use it.
Ma'am, if there are no more questions, then we can wind up for today. Thank you so much for your support, your time. Thank you so much for joining for today's session. Thank you, ma'am, and thank you all for joining for today's session. We'll see you on the next session. Bye bye. Bye, ma'am.
Bye. Thank you.